Hello, everyone. Welcome to this interesting meeting this evening. I'm Professor Sebastian. I want to talk about why we should care about green endoscopy. I'm just going to put these pictures up because I believe the picture is worth 1,000 words. Yes, we have had a pandemic. Yes, we are having a recession. But I think what is coming in the next tsunami, we should be very much conscious. And for that, we need to have a coordinated and sustained effort. So the slowness at which some of us may have acted during pandemic is simply not an option, because climate change is no longer some far-off problem. It's happening here, and it's happening now. So why should we care? But if we don't care, who will care? This is David King, who was the previous UK chief scientific advisor. He said, climate change is by far the greatest threat to the world than international terrorism. Because climate change threatens to undermine the last 50 years of public health gain we have made. And healthcare accounts for 4.4% of the global carbon footprint, and in some countries as high as 8.5%. So we have to really think about environment when we are thinking about the cost of healthcare while we are coming out of the second tsunami of economic hardships. So the impact of climate change on every aspect of human health is now very well documented. Not just the communicable diseases, not just the cardiovascular illnesses, but think about the mental health impact of climate change, which is happening across the world, which is actually resulting in civil conflict, forced migration, and subsequent mental health impact. We need to think about greenhouse gases in terms of the scope. Mainly in relation to healthcare, we have to think about particularly the scope 3. That is where a lot of our greenhouse gas emissions related to healthcare is coming from. And if you further divide this further, you can see that a lot of the impact of a lot of our actions are related to the supply chain and the devices and the medicines, and a certain degree in relation to our organizations. And these are figures from NHS England. In the UK, 22.8 million tons of carbon emissions from our healthcare interventions. And look at that figure below, 80% attributable to clinical decisions and models of care. So it's very much in our power to do that. So what about endoscopy? Why are we talking about it? Because it is indeed the third highest healthcare waste generating department. Because we have high throughput caseloads, we have multiple non-renewable waste streams, and we need to improve that. And we have numerous hospital visits for patients and relatives. And indeed, it is the second highest waste generator per clinical procedure. If you take an endoscopy, 2.4 kilograms of waste, 3/4 of which waste goes to landfill. Can we change that? And if you have to think about it in a more logical sense, it's equivalent in the US, an annual endoscopy procedure total is equivalent to 24,900 passenger cars. And this has been looked at in an individual small unit at microsystem level. And you can see from a single endoscopy unit, you can read the figures for yourselves, massive amounts of carbon production. A lot of it is down to things such as decontamination. And I think this meeting is particularly of relevance from this point of view. We are still needing to use 70 to 100 liters per cycle for decontamination. And this is RO water or reverse osmosis water. And a great deal of effort is done to make this decontamination process as safe for the patients. And we need to work on this and keeping the environment in mind. What about the biopsy forceps? We take multiple biopsies and interventions for reducing biopsies or technological advances to facilitate that. Maybe one way we may be able to do that. And that's already proven in this nice study which was done from United States. Or we can have a simple intervention, reduce the size of the ports. You can see in the picture there. So small gains, low-hanging fruits. What about in the use of nitrous oxide, which is indeed more harmful than many of the other pollutants which we use? And once it's released, it can remain in the atmosphere for 110 years. And in some healthcare systems, it is used for patient convenience. But have we actually spoken to the patients, given them the environmental impact of this intervention? Perhaps we should involve patients in discussion of choices. But if I have one message for all of our healthcare colleagues today, is this one, that we do a number of procedures which are really not indicated. And the greatest waste is a procedure that never needed it in the first place. And we should still keep this principle of reduce, reuse, and recycle when we are thinking about sustainability in our units. And that is why, in the midst of the pandemic, some of us brought together a group of clinicians and other healthcare professionals to develop this green endoscopy movement. We then went on to educate, inform, and generate discussion through a number of publications from the group to make awareness of environmental sustainability equally in par with safety. And if you look at the patient journey in the endoscopy unit, we have identified all steps, starting from thinking about alternatives, all the way to post-procedural follow-up, where we can have interventions which can reduce our carbon footprint. Simple thing, reduce the number of endoscopy procedures, and it's been proven that enhanced wetting procedures can reduce the number of unnecessary endoscopic interventions. We came together as a group to produce the British Society of Gastroenterology Joint Accreditation Group and Center for Sustainable Health Consensus Guidance. This is for practical advice for endoscopists, other endoscopy staff, and other collaborators in an endoscopy environment to find sustainable ways of working, to do their bit for our planet. And that's highlighted in this schematic, which is downloadable from the publication. We have identified 13 key areas to work towards a dream green endoscopy unit. But the key thing is to have the culture change, the philosophical change that the planet needs us. And do we think as endoscopy professionals about sustainability during our endoscopy list? In other words, are we thinking about the planet in addition to the patient? And I'll come back to this one. 80% is attributable to clinical decisions and models of care. And that's where industry also has a place to play. You can see right from the manufacturing all the way to the disposition. There are some areas where there is heavily carbon resource intensive. So it's in their interest and in our interest to work together to improve this process throughout that journey to make it more sustainable. And it may be that we will have to act as the tail of the dog, or who is actually going to wag the tail. Should it be the industry wagging, or should it be us? But what I do know that we need to hold each other to account. Procurement, supply chain, packaging, delivery, and find innovations. And there are already organizations which are doing that. And we need to learn lessons from the plastics. Over a period of time, cultural change meant that we are now using reusable bags for our shopping. Because there was finances involved, we as consumers should be using this financial might to provide more innovations so that we come up with sustainable solutions. Because money, at the end of the day, will speak the right language. And they're already starting to listen. I have no conflict of interest with this particular company. Already in the front of their website, there is an energy management strategy. Same with another company. They're producing innovative solutions to reduce the need for electricity in some of the decontamination processes. And sustainability has been high on the agenda of PENTAX, for example, evolving to produce sustainable solutions. Because at the end of the day, as I mentioned about the 80%, the material components are very important in the sustainability journey, and all of these can be worked on. And the elephant in the room is, let us have a proper, informed debate on single-use devices. So, endoscopy needs to reinvent itself. It needs to have a sustainable future, and that has to happen fast. We simply cannot go back to business as usual. We need to be part of the solution, not the problem. There are several quick, small gains which we can do right now in our own professional life, in our own unit, using 3R principles. But key is to work together with the industry and allow them to play their part in their journey for environmental sustainability. I look forward to hearing your discussions for having this picture in front of us for a long time, for my children and for the future generations. Thank you.
Thank you very much, Professor Sebastian. And please join me here at the table so we can have some Q&A after the next two presentations. And our next speaker is Professor Heiko Pohl. And if all is well, he should be online with us. And I'm very happy to give him the floor. Professor Pohl.
All right. Well, thank you very much for inviting me to this conference or symposium. I'm going to try to talk about why. So the center of this discussion is really the ESGE, ESGENA position statement that was published in 2022. And I'm going to start with the motivation why the statement was even drafted, and then I'd like to present some details on that. And finally, I want to talk about some initiatives and an outlook into the future. But first of all, I really thank Professor Sebastian for this wonderful presentation and the reminder that we should be touched by what we see. And the motivation to do something is coming from how we are being touched. So I'm really grateful for also giving this framework or this frame in this presentation. I also, in the beginning, I want to make sure that we forget it's not just about climate change. There were a couple of publications, this one from Science 2015, that highlights the planetary boundaries. In other words, domains on the planet that we as humans should not overstep for us to continue to thrive on this planet. And climate change is one of them. We're on the yellow zone there, but biodiversity loss is a very other important one where we already reached the red zone. And then not to forget about pollution, and it's particularly the nitrogen and phosphorus runoffs that have a major effect on the fertility of the soil. Of course, they all interconnected and influence each other and have also an effect of climate change. So just want to highlight it's not just about climate change, but also the environmental impact of our activities. This was a somewhat shocking news to me in 2020. This paper published on the human-made mass that exceeded in 2020 all living biomass. And I want to draw your particular attention to the mass that we produced as humans in plastic, which doubled the mass of what is living on the planet as animals. So more plastic production by us than we have living animals on this planet. And also construction is a major contributor, and we have already constructed more than we have trees or shrubs on the planet. So those are shocking news in terms of what we do. Now, of course, Professor Sebastian mentioned this. There is this interrelationship between the environment, climate change, the effect on health, the effect and the strain on the healthcare system, but also the contribution of healthcare on the climate and the environment. So what can we do? Yes, we have to adapt, but we should also try to reduce our environmental impact. And we heard the worldwide contribution of greenhouse gas emissions by the healthcare sector is 4.4%. In the US, it's 8.5%. So what's the solution? Well, sustainable healthcare, and particularly GI endoscopy practice. And we can talk a lot about what sustainability means, maybe in the discussion, but I just want to highlight that what has happened over the past 2-3 years in that respect in our area is shown here on this timeline. There was a first abstract presentation in 2020 on this topic. The WGO formed a working group in 2021, I believe. Then there were a lot of commentaries published on the association of our practice on the environment. First studies came out. The ESGE strategic plan in 2021, which was like the first really outlined path towards sustainable practice. And then the ESGE, ESGENA position statement in 2022, the US Multi-Society Task Force strategic plan on sustainable GI hepatology practice, also late 22, and then this year, early this year, the ESGE consensus statement. So I think we have really achieved a lot in the past 2-3 years. So if we think about more particularly about our endoscopy practice, and Professor Sebastian pointed out this already, so we have several things that really affect the environment of what we do. Of course, in the center is performing the endoscopies, and we use endoscopes, we use accessories, we use medications, but we also have to consider the area that we work in, like the hospital, the infrastructure, the energy that we use, the heating, ventilation, air conditioning system, and then the organizational aspects that also affect the environment, and where we also have potential to improve what we're doing. And then patients and staff have to travel to perform or receive an endoscopic procedure. And of course, we have educational and research activities. And at the end of it, we dispose a lot of equipment, and we're going to talk more about that. So the ESGENA position statement was published in July 22. And if I may say, it was really a tremendous I want to say like creation, because it was done within a very short period of time with extremely collaborative efforts that was between many participating endoscopists and other specialists. So ESGENA includes 39 statements towards sustainable GI endoscopy practice. And on the path towards the green endoscopy, those are the more or less 8 areas or categories that are covered in this statement. So at the center is clinical management, then there's logistics, particularly focus on single-use instruments. Then there are sections on research, education, policymakers, industry, and green quality. And the 39th, the last statement, is to commit to a net zero path by net zero endoscopy practice by 2050. I'd like to highlight some of these statements or in some of these areas. So the first one, with respect to clinical management, there are 9 statements. And within these 9, I just want to highlight 5. And we heard earlier that performing procedures that are appropriate may be the single most relevant impact we can have on reducing our carbon footprint and environmental impact. Not doing the procedure that's not indicated, trying to do the procedures that are of high value. So the interesting thing is that if we were to follow the current guidelines, we would probably significantly reduce overuse and overutilization and thereby reduce our environmental impact. Then we should also consider alternative tests that are instead of endoscopic procedures. One example would be helicopylori testing that does not require biopsies from the stomach, can be done differently. And we heard about reduction in taking biopsies. And then the rational use of accessories and also applying the appropriate technique. So that really requires for us as endoscopists to think ahead. What I'm going to do for this patient in this procedure? What accessories, instruments do I need? Do I need to do 2 or 3 instruments, or can I get by with 1? If I have an upper endoscopy and lower endoscopy, can I just use 1 forceps biopsy for both upper and lower? So those are the things that are just very tangible and can be implemented more easily. I want to talk about single-use accessories and endoscopes as one of the categories within this statement and highlight a couple of aspects here. So one of the points is that guidelines should consider the environmental impact. Currently, the guidelines do consider evidence from studies and graded accordingly. The ESGENA statement suggests that environmental impact should also be considered when establishing guidance. Then there's an emphasis on collaborating with industry, and we'll talk more about this a little later. And the suggestion to change our endoscopic equipment following an environmentally sustainable design. And then there is a general statement for single-use endoscopes, and the recommendation is to against the routine use of single-use endoscopes. So why is there such an emphasis on single-use accessories and endoscopes? And I just want to come back to the sources of our environmental impact, particularly the carbon footprint. Comes from the supply chain, most of it. So in general, it's the manufacturing and the transport of a device generates most of the greenhouse gas emissions. In other words, when we take the snare or the biopsy forceps out of the package and use it, most of the carbon footprint has already been generated. So the other aspect is, of course, what we see is the waste that we're producing. So we showed or waste is being generated per procedure. And that is relevant because plastic ends up very often in landfills and is maybe washed out into sea and has an effect on the wildlife visibly here, but also as microplastics that are already within all of us and we breathe it in. So if you have not heard, there was a recent UN summit to end plastic pollution in Paris, and there was a very strong commitment to end plastic pollution by 80% by actually, this is, I think, 2030, so the 2024 is not correct. So just want to say that it's not just about the emission, it's also about the waste that we're producing. So what are possible solutions to this? And we have all heard about circular economy that takes out the waste, so minimizing waste or leakage by reusing or prolonging its the use of an instrument, sharing it, repairing it, remanufacturing it, and recycling it. So following the principles of a circular economy. Again, the effects here or the implementations that should happen is to reduce single-use devices and increase reusable devices, but at the same time also optimize reprocessing so that the lifetime of an instrument increases, but also that the reusable process or reprocessing process does not affect the environment as much. The third and final category I want to highlight is related to industry, health insurance, and healthcare providers. And the statements here say something about to disclose the environmental impact of a value chain, and that goes to industry partners, to recommend manufacturing environmentally friendly materials and devices. There is a strong call for changing the expiration date and planned obsolescence of endoscopic devices. And then we heard already earlier about the idea of green purchasing. So selecting those devices, if they are of similar quality, that have a lower environmental impact. So finally, I want to just talk about current initiatives and outlooks into the future. And I'm just highlighting here some working groups that have been established in Europe, worldwide, and in the US. And the ESGE working group is very active, maybe spearheading lots of initiatives. I'm chairing the US Multi-Site Task Force on Climate Change and the ESGE Task Force on Sustainable Endoscopy. Those working groups also work together, and I just want to highlight in those several domains, or some of these, what we've achieved over the past couple of years. So within the clinical setting, we are increasingly understanding the environmental impact of what we do. So there's an increasing number of studies being published that include waste assessment and carbon footprint. There is more specific guidance from the societies what to do, what endoscopists and units can do to reduce the environmental impact. I want to highlight the 5 R's of the ESGE, which have been published over the past few months in the newsletter, focusing on reducing, reusing, recycling, researching, and rethinking. Really practical guidance. Within education, we all have seen more webinars, and particularly the 8-part series of the WGO that is still ongoing. And then there have been dedicated sessions during conferences, ESG, ACG, and recently DDW. In research, just highlighting that we're working within the ESG to have a dedicated research proposal so that people can particularly apply for this. 1 grant has been awarded already to measure the carbon footprint of GI endoscopy. Within the societies, the ESG has completed a survey to members to understand their perspectives. And in the US, we're trying to measure the carbon footprint of societal activities. And we also have established a sustainability fund. And finally, about industry, there have been many individual discussions between representatives of industries and those that are very enthusiastic or, let's say, involved in those in green endoscopy working groups. There has been one formal on-stage discussion at the AGA Tech Summit earlier this spring, which I think is beautiful and shows us that everyone is on board towards sustainable practice. Just highlighting briefly the next steps, 2 points, just in the interest of time. We have to better understand what we're doing, understanding the environmental impact of our practice, and trying to implement practice changes to reduce the environmental impact. One idea is to have pilot endoscopy sites that implement sustainable practices, and then share what has been learned for others to follow those role models. I want to just highlight one more point before I come to my final slide. Shifting the burden. This is coming from an environmental studies professor from our college. If we have something that we want to change or solve a problem or a symptom, we have to think about fundamental solutions to address the underlying problem. We have to really understand if this is what we do as a Band-Aid and only prolongs things or reinforces a so-called locked-in, or whether we have a fundamental change. So recycling, for instance, could be considered as something that is currently, because not everything is being recycled and reused, could be considered something of a symptomatic solution that makes us just feel good. So we need to have a fundamental solution that really changes the paradigm of what we're doing. Okay, in summary, it's really great to see how much activities have been going on over the past 2 years, and there's a lot of enthusiasm. I'm really glad about the collaborative effort with industry and also across continents, and it's a global effort. The first steps have been taken. The path forward must be inclusive. That includes all stakeholders, and engagement with industry is essential, and we need to look for creative solutions. All right, thank you.
We'll be seeing you after the next presentation back in the Q&A section. And to keep the program rolling, we're now going to hear from Professor Raf Bisschops about the power of choice.
Good evening, ladies and gentlemen, and thank you for tuning in. So I will talk a little bit more about the role of reusable and single-use endoscopies in this talk, a choice we can actually make in our daily practice nowadays. So you heard already from the previous speakers that obviously healthcare has a significant burden on the environment. Actually, if healthcare would be a country, it would account for the 5th largest production in environmental burden and CO2 production and greenhouse gases as such. As Professor Pohl indicated, there are several ways we can produce this burden. And in fact, 71% of this burden is derived from healthcare supply chain through production, transport, and disposal of goods and services, including pharmaceuticals, chemicals, but certainly also medical devices and disposable material. So if you look here, mainly the burden comes from the distribution of electricity and transport, gas, everything that's involved with production, transport of these disposables. So we need to think consciously about this if we want to take this matter seriously. You just heard this wonderful paper and position statement that was issued last year that basically highlights all the different points we can think about when it comes down to taking care of the environment and daily practice in endoscopy. And certainly one of the important points there is to think about the use of disposables, what kind of burden this puts on the environment, and what about the waste production there. So this is what this talk is about. What can we choose? So let's talk first about single-use versus reusable and even semi-disposable new solutions when it comes down to using endoscopes. So basically, the statement from ESGE says that we should not use this systematically, but obviously there could be a role for considering these tools in highly selected patients on a case-by-case basis. So the first question to wonder and to ask yourself is whether the risk of an endoscopy to get an infection is in fact high. And this is not really clear. There's no consensus on what clearly constitutes an endoscopy-related infection. And the risk estimates, they range from 1 in 20,000 to 1 in 1.8 million if you look into the literature, so it's quite broad. Also, if we look at some cost-effectiveness analyses of single-use endoscopes, they actually use a much higher figure for risk, which may in fact lead to an overestimation of the true cost-effectiveness, also something we need to take into consideration. And then finally, the risk of a clinically relevant infection is probably very low, since multiple steps are needed. So you need to have a high enough infectious load in the endoscope, leading to bacteremia, and then also bypassing the immune system of the patient. So there needs to be a combination of a frail patient and also an infected scope with sufficient bacteria. Some of these conditions may already be present also in the patient, in particular when we think about ESCP and infection, and may not impact clinical relevant outcomes. For instance, we have the example from an RCT on endocarditis prophylaxis showing bacteremia in 23% of patients after teeth brushing, or even 60% after tooth extraction, suggesting that bacteremia as such does not always lead to a subsequent infection. However, there is a risk associated, especially if we look at ERCPs. Between 2008 and 2018, there were 24 reported clusters of duodenoscope-associated multi-drug-resistant microorganisms, including 490 infected patients and 32 worldwide deaths. And probably this is an underestimation because these were very well looked into. And what are the factors? Well, if you look at this study from Holland, they looked at the factors. First, they had 102 patients, and 81 of them, they took cultures, and they could find 27 multi-drug resistant Klebsiella pneumoniae. And 10 of them actually developed an infection, but the other ones are carriers. And interestingly, they did a root cause analysis in these infections and looked what the factors were that, in fact, were responsible for this. And many of them are human or really product related. So miscommunication is an important factor. So the scope disinfection is really important. Sometimes damages are not detected in the scope or they are inadequately repaired. And finally, the design of the scope itself, which makes it sometimes more prone to defect, but also the forceps elevator in particular and the lever and the instrumentation port sealing is a factor that is important. So if you look at these pictures, you can understand that an ESCP scope has to endure a lot of mechanical stress force during the actions that the endoscopists take that can lead to damage and subsequent colonization. So the easy solution would be then to use a single-use duodenoscope for everything, and would this solve the problem? However, this is what this session is about. We need to think also about the environmental impact of disposable endoscopic equipment and endoscopes. And Heiko Pohl's group really nicely assessed that every endoscopic procedure generates 2 kilograms of disposable waste already, if you calculate everything. And this corresponds in the United States to an equivalent of 117 soccer fields with 1 meter depth of waste, or about 25,000 passenger cars. So if you were to substitute all the reusable endoscopes with single-use endoscopes, you obviously would save on the production of CO2 or water use when you think about the reprocessing. But for all the other processes, the natural resources, manufacturing, transport, and procedure, and the disposal of the waste, the burden would go up significantly. And in summary, 40% of waste would be added if all the reusable endoscopes were replaced by single-use endoscopes, even if you calculate for the less reprocessing burden. If we look specifically to ERCP, you can see, according to this study, that the CO2 production per single-use endoscope ranged between 36 and 71 kilograms, and this is only 1.5 kilograms of CO2 for reusable duodenoscopes. So basically, this will increase the burden by 24 or 47 times. However, there is a way in between specifically for ESCP, which is one of the clever innovations that was already alluded to, is to just use a reusable cap on the top of the duodenoscope that would take care of the elevator, which is a sensitive part of the duodenoscope. And in fact, if you calculate the CO2 burden here, this is just slightly higher, plus 0.1%, or almost equal to the reusable duodenoscope. So this is a clever solution that is also accepted recently by the FDA, as you can see here, that they do take the concerns about contamination of the duodenoscopes really seriously, and they say that there should be alterations in the design of these scopes by single-use endoscopes, but also disposable end caps that have a good outcome in terms of infection. I would also like to address another choice we can make in everyday endoscopy, and that is to take care of the quality of what we're doing. Because basically, the endoscopy that doesn't need to be repeated, or the endoscopy that doesn't have to happen anyway, is the best for the environment and probably also for the patient. So this is clearly also from the ESGE position statement, where that it suggested that adherence to quality metrics also reduces the environmental impact. And this starts with the most simple basic thing. The endoscopy that you don't need to do doesn't cause any burden. The patient doesn't have to come to the endoscopy suite, so there's no transport. You don't need to reprocess the scope, and it's nicely listed in this position statement. For instance, short segment Barrett's, inlet patches, low-grade inflammation in the esophagus, limited intestinal metaplasia in the stomach, subepithelial lesions that are small, and for also something that people very overdo a lot is repeat endoscopies. And it's clear that for a small number of small adenomas, you don't have to survey the patients. And I think this is something that also needs a change in attitude if we take environmental burden of endoscopy seriously. So also the quality of your endoscopy, if you perform a high quality endoscopy, it also means high quality reporting. And this in itself can also save endoscopies. You need first to make sure that the bowel prep is good, because then you save another redo endoscopy. That makes sense, I think. And that means that you need to clean and optimize your level of cleaning during the endoscopy. But also the reporting is important. You can write something down like nodular mucosa somewhere in the colon, or you just take a picture. And if you're not going to take out this polyp yourself, you can send this picture to the referring physician. And then he can say, okay, I can do this with an EMR, and you can allocate an appropriate time slot for this. And most importantly, if you make sure you have a good reporting and good photo documentation, this leads to adequate planning, which is cost efficient for your organization and quality, but also less of a burden, because very often we get patients referred with polyps that are not amenable for endoscopic resection. So that means the patient has to undergo a new endoscopy, which is actually unnecessary, then to just find out that he had to go straight to surgery. And obviously there's also so low-hanging fruit, I think, for improvement, both for patient care, but also for environmental burden. Also, do a good endoscopy. Follow the protocols that are there. So if you follow the Seattle protocol and it's a short segment Barrett's below 3 centimeters, you can wait for 5 years, because this is the best way to survey the patients. And finally, I would like to emphasize and support some disobedience for ridiculous nonsense matters. So what does it mean? For instance, we were forced to use sterile water to rinse off stool in the colon. This doesn't really make sense to me at all. So this is some of the things we have to really think about. Sometimes things are implemented that don't make sense at all, and I think here we can also save, again, on the environmental burden. So in summary, Mr. Chairman, ladies and gentlemen, I think awareness of climate change and environmental impact of healthcare is growing, and we should make choices as physicians to balance patient safety and the environmental burden. Reusable endoscopes should be the standard, I think, but for high-risk procedures such as ERCP, reusable endoscopes can still be the standard, but disposable end caps are probably preferred nowadays to reduce the risk of infection. Single-use endoscopes could be used in selected high-risk patients, as we do in our unit as well. The biggest benefit in environmental impact, however, is found in high-quality endoscopy, and especially in avoiding unnecessary procedures. And in the future, I think some civil or citizens' disobedience against nonsense measures that cause unnecessary environmental burden will probably need to be more executed. Thank you for listening.
Thanks a lot for that, Professor Bisschops. And please join us here at the table together with Professor Sebastian and online with Professor Pohl. So we have 3 professors now here amongst us, so I'm going to imagine that the answers are going to be of extreme high quality, and I'm sure that we'll be able to tackle some problems here. Some questions have already come in, which is great, so please continue to enter those questions in the chat. And maybe starting with you, Professor Sebastian, there's a question for you. You already mentioned it briefly in your presentation. You were talking about the big pink elephant in the room. The question is, how do you see the impact of single-use endoscopes on the environment? And what is your take on single-use GI endoscopes?
Very good question. It is indeed probably the elephant in the room. That's why we are discussing it today. Let me give you another analogy. We don't use a sledgehammer to crack a nut. But what the problem we have is that we don't know as yet. There is a problem with infections, as quite highlighted already by Ralph, Professor Bisschops. How much is the degree of that problem? And what should be our solution? I should say solutions, more than one solution, to solve that problem. So single-use scopes may be a solution for some of that problem, but not for all of it. That's why I meant it may be using a sledgehammer to crack a nut.
Okay. Professor Pohl, would you have anything to add to that, or do you have any other wise ideas or thoughts?
I really like the idea of the sledgehammer. I think two things. One is, I think we have a problem. We have to understand the magnitude of the problem, which is patient-to-patient risk of transmission of infection. And then we have to think about the solutions. And single-use scope is a solution, but it may not be the best solution because of all the consequences we mentioned already. The other thing is also that when we look for a solution for a problem, it's really hard to predict the unintended consequences. So we may think about one consequence, but there are downstream consequences that we might not foresee. It's hard to predict it because I say we cannot predict the unintended consequences. But if we think a little bit broadly, for instance, if we changed from single-use, from reusable duodenoscopes for ERCPs, then all of a sudden there's a market for other single-use scopes where there's not even a need to change, like colonoscopies and EGDs to be performed with single-use scopes. If we were going there, it's hard to really turn the clock around. And then we really lost the ability to use any reusable instruments. And then we're so far down the streams towards linear economy that it's hard to turn it, even harder to turn it back. So in that sense, I think we have a locked-in situation, what I mentioned before, and that's not a true fundamental solution to the problem. So I think in general, we have to think more about what is the real problem, the magnitude of the problem, and what is it what we want to try to, what are the possible solutions? I mean, it gets into a little bit of a philosophical discussion, which I think we might also have more, because very often we have like a knee-jerk reaction. We have one problem, title page on some big newspaper, and then we have to react, and that's not good.
Thank you for that. Professor Bisschops, maybe you can also enlighten us a little bit about this.
Yeah, I think another counterpart of that coin is that you would also decrease the quality of your endoscopy if you were to change all the reusable endoscopes, then the gastroscopes and the colonoscopes by single use. I mean, we are so used now in conducting optical diagnosis, we are getting it. That's another way where we're moving forward. And that would be actually a downside of that because, I mean, probably they will not agree, but the quality of the image we get doesn't meet the quality we get from reusable scopes in terms of optics and what we can achieve there and resolution. So I think this is really also an important issue besides the fact there could be a side effect that is also negative from single-use endoscopes, for instance. So that's also an important issue to emphasize.
Yes, but are there already policies on when to use single-use scopes and when not? Is this already clear for everybody?
No, I think it's, at least for us, it's more per hospital decided. So I think we have a clear idea in which patients we are currently using a single-use ERCP scope, and that's a limited number of patients that have a high-risk profile, may have already ongoing infections. So, and we don't want to transmit one thing from a patient to another. You never want to do that, but it's particular in those patients that are immunocompromised. And another potential indication we're thinking about is more in terms of logistics. If you go to emergency department for a bleeding, there I think it could be useful because you sometimes also have a long lag time before you can actually start the processing and the disinfection of the scope, which in fact is the most important part of getting rid of the bugs. Right?
Yeah. And Professor Sebastian, UK is a front runner. Do you already have a national policy on when to use and when not to use single-use scopes?
No, at the moment it is very much on a case-by-case basis. But I would put a positive spin on the debate. The very fact that we are having this debate may actually stimulate innovations and look at other pathways in that journey of endoscope manufacturing till completion, whether we can have better sustainable solutions in each of those. So innovation may actually come as a positive byproduct of this debate what we are having. But right now, it has to be based upon, like any other healthcare intervention, what's the benefit, what's the risk. But in that equation, we should add not only just benefit and risk to the patient, but also to the environment.
And do you have the idea that the UK is a front runner within this?
I think a number of organizations, we started, we were an advocacy movement as Green Endoscopy. It has grown in momentum, but incredibly grateful to leaders such as Professor Bisschops and Heiko Pohl, with other organizations, ESGE, the AGA. Yes, BSG has led, but it has to be a global effort. And that global effort has to include the industry. And I might even go as far as and say we should also include our consumers who are our patients.
Yeah. Professor Pohl, maybe you were also one of the authors of the ESGE statement. Is policy about single use at all a good idea, or is that too limited? Should we keep it case by case? What are your thoughts on that? Also, in the whole green debate.
Is your question related to the general approach to reusable single use, or can I rephrase that question?
Yeah, I mean, should we have a more clear policy worldwide, kind of, or at least within Europe, when we would or would not use single-use scopes? Is that at all useful or not?
Well, I think it's not that easy to answer. I think having a policy where there's something of lack of data, so it's hard to do. I think what are we trying to achieve? I think we're trying to achieve to have a lower environmental impact, right? So how do we achieve that with respect to single-use scopes? There are different things. One is we can reuse everything, and we should try to have everything kind of change into the reusable aspect. But then there may be downstream effects of reprocessing. We don't know what the reprocessing effect is of, let's say, reusable instruments, or the quality aspect. The other possible solution would be we just redesign things. And Professor Sebastian mentioned that if we have environmental designs, that might be a possible solution. For instance, if you have a handle that would be biodegradable, or if we have module components where part of it would be reusable in the sense that we just have a circular economy, it's being reprocessed or remanufactured and used in the same instrument, for instance. So I think there is a lot of potential. We never really thought about creating instruments that are following an environmental design, and I think we should start doing this. So, and coming back to your original question, should we have clear guidance? I think we have to have guidance on restricting potentially dangerous developments that would be, in my opinion, really restricting the universal use of single-use endoscopes.
Okay.
So just because of the environmental design, that would be my thought to that.
Thanks for that. Maybe moving to you, Professor Bisschops, there's also a question here from the audience, which is, what is the biggest barrier that you foresee in achieving net zero in endoscopy by 2050, and how can we overcome this barrier?
The biggest barrier,
yes,
is to stop doing unnecessary colonoscopies and gastroscopies.
Okay, and how are we going to achieve that? Because I think one of you already mentioned the guidelines already say you shouldn't be doing it, but we're still doing it anyway. So guidelines are not the solution. How are we going to do that then?
Well, as Professor Sebastian says, money speaks, and unfortunately this is also true on an individual level. As long as we have a per-pay service, then, this is probably a driving force to conduct an examination together, obviously, with the indications and the patients presenting themselves. But on the other hand, for a lot of the endoscopies we do are just for surveillance of patients that will never run into any problems, right? So it takes patient education, mainly reassurance that if they have, for instance, one adenoma at the age of 55, that they most likely will not die of colorectal cancer. And if they have a short segment Barrett's and they're 75 years old, that there's no need to do a yearly endoscopy. So these kind of things needs education, both from the patient side, because sometimes they show up for an endoscopy that was not even planned, right? So it's on both sides, I think.
Yeah.
The other issue, I think, is the waste in the endoscopy units. Now everything is binned and incinerated. So I think it's really low-hanging fruit, and you already alluded to that. But that will probably not be the barrier, I think, because I think people will be open for that, to start recycling. So that will be the easy part. But the most difficult part is probably the things that are not needed. Right?
Okay. And Professor Sebastian, you also mentioned that in your presentation. Procedure not needed, that's where we can get the waste out. Is it indeed to solve this, it's almost impossible to solve because of the economic reality underneath it? Or how do you view this?
Yes, I think it is solvable. I'm an eternal optimist. I think this movement has already started, okay? And we have to be ambitious, okay? And by the solution to problems such as this is more research and education. And that education not just involves just the healthcare providers, but also policymakers, the payers. Okay? A high quality examination may be remunerated at a higher level for a lower number of procedures. You know, that's a solution. So to me, it's already started, and we will get there. And we have to aim at the sky, which is net zero by 2050, and the UK, we have committed to 2040. That's the high ambition. If you don't reach for the sky, you won't get off the ground.
Yeah.
Let's work towards it.
So you already see it moving into the right direction?
Yes, I think the momentum is started, and it's important that collaboration with the industry, with academia, research, and education, and events such as this to raise the awareness of the necessity of this, and investing more into sustainable alternatives. Heiko has made some fantastic points. There are technological solutions which we should come up to reduce the impact even of single-use endoscopes.
Yeah, thanks for that. Professor Pohl, anything else, maybe another barrier that you foresee achieving the net zero in 2050?
I think it's us. I mean, I'm just, echoing what Raf was saying and Professor Sebastian, but I think we are creatures of habit, and if we reflect on ourselves, our relationship to nature, and let that sink in, and then behave accordingly, I think that would be a big step. So I think we have to include us as individuals in the conversation. That also includes the patients. I mean, how difficult is it for us, for you and me, to really do recycling at home, right? It's really tough because we just have certain ways of how we do it, or reducing our travel needs or whatever. It's an effort, and I think that's something we all have to strive for. And in terms of our patients, there is this great, I've never talked to them, but there is this sustainability group in Oxford that trying to understand sustainability principles in healthcare. And it's one of the 4 pillars is environmental issues, reduction in it. And the other 3 are related to administrative services, lean services, and the other 2 is, one is prevention, and the other one is self-empowerment. That means patients to be self-empowered, to take their health in their own hands. And for instance, if we did this, including us as providers, and prevent things not just with the first colonoscopy at the screening age of 45 or 50, but throughout life, having a healthy lifestyle, plant-based diet, I think we could also, I think that's also needed, and reaching for the sky. I think we have to re-examine our own behavior, our own culture, how it's supported, how our current habits are ingrained in society. And so it's a collaborative effort beyond healthcare, actually. But I really like that idea of reaching for the sky. You have to reach for the sky. And it's probably an ongoing path. It's not something we want to achieve. There's not the goal of now we have it achieved. I think it's an ongoing effort, an ongoing path towards walking this, towards sustainable lifestyle, green healthcare.
Yes, thanks for that. You were talking about self-empowerment, and there's a question here for Professor Bisschops from one of the people in the audience. Do you think that in the future, patients will actually be involved in the choice of endoscopic equipment used, for example, single-use or reusable? You think we're going to ask that to patients?
I honestly hope not, to be honest. I mean, informed consent and everything is very important, right? But I think we also need to communicate the risk of a procedure accurately to patients. And the general rule there, if the risk is extremely low, it doesn't even need to be in the informed consent, right? Unless it's very bad, like mortality. An informed consent will always state there is a certain mortality which is usually unknown for a gastroscopy, for instance. But the risk of a basic gastroscopy to get an infection is so extremely low, probably 1 out of 1.8 million. So, and this too, I mean, I think it's the balance there, if we take environmental burden into consideration, doesn't justify that choice to make, in my opinion. I don't know what others would say about that.
What do you think, Professor Sebastian?
I think, an informed patient is a partner in that decision making. So it's our responsibility to give both sides of the coin, as you rightly put, Ralph. There are some risks with any procedure, including the use with the reusable scopes. But they also need to be informed about the consequences. And in my experience, patients actually value that discussion. It doesn't mean that they are given, all choices are always available in all healthcare systems, but being aware, being informed, and that's the fundamental principle of informed choice. And let me give you an example. In the UK, nitrous oxide is quite commonly used for colonoscopy, one of the most polluting gases. But the British Society of Gastroenterology, through the consensus, developed a simple information leaflet along with the consent process. In some centers, that has reduced the use of nitrous oxide by simple changes to attending for a procedure from the patient's part. So patients being empowered to make that decision. And that has reduced in some centers. So simple interventions involving patients, I do think that has a future. We are needing to be partners in healthcare with patients, not any longer dictating how they should make that choice.
Okay. Professor Pohl, your thoughts?
Well, I really have nothing to add. I think in some sense, well, maybe I think there is a fine line between the quality that we want to provide and that is based on our expertise as the physicians, but also what Professor Sebastian was saying, to involve the patient in the process in terms of informing the patient about all the aspects of care that are relevant. So, I think I'll leave it at that.
Okay. Another thing that was interesting that I heard you say, Professor Bisschops, was public disobedience against nonsense. And I know that we were talking about waste, or somebody mentioned waste. Do you have any thoughts about that? Because I hear that there are a lot that, for instance, different parts of the procedures that you're using in rooms have to be then taken out again, or all the instruction for use manuals have to be printed out. But I also understand it's because of regulations you have to do that. So please enlighten us a little bit. How can we change this nonsense?
It's country by country, but I mean, I think the general MDR rule still is that anything that comes into the patient room, endoscopy suite, goes into the medical waste bin, which goes to the incinerator. Although many of the disposables that we use, I mean, implants or biopsy forceps or whatever, they come in packages that never touch the patients. They're from plastic and paper. But we are currently not always allowed to recycle them like we do at home, as Heiko said. While it's actually very easy to do so. It's not because something is in a room that it's contaminated as long as it hasn't touched the patient. Yeah. And even worse so are the instruction for use the instruction for use leaflets. They're not just leaflets, they're sometimes booklets. So if I do a week of RFAs where I treat 25 to 30 patients, I end up with a pile like this of IFUs, which basically goes to the incinerator. And the worst thing even there, and that's where the medical device regulation should come in, they should all be printed on virgin white paper. It cannot even be recycled paper. So there cannot be any recycled material in the packages of any medical device at this stage. So I think this is something where we have to collaborate with the regulatory instances, because it's really a no-brainer to take that on and to recycle all that material.
Yeah, and are you doing that, for instance, in the UK? Are you?
I think it's absolutely essential we work with the regulators, because regulators have, based on the data what they had before, it's for us to create the data one way or the other, have that discussions again with them, what is possible, what is not possible. For example, we have gone away from signing agreements on paper to digital signatures, digital information leaflets. Why do we need to print reports?
But are you talking about this with, for instance, in the UK, the MHRA, yes, and are they susceptible to these kind of suggestions?
They are looking for us. It's in our gift to provide them the information and guidance. So as a community, we should create that evidence set, even in areas where difficult to get evidence, like the infection risks, because it varies very widely. Let's give them the right evidence so that policymakers can then guide us in a legal environment to the right decisions.
Yes.
And I think patients should be involved in this as well. Patients are more, the current generation are more environmentally aware, and they are starting to trade off some of their comfort, some of their disadvantages of a particular intervention, and marrying that with their duty towards the environment. And that generation is already coming, and let's work with them.
Professor Pohl, is that also your experience in the US, the enormous amount of waste and maybe even useless IFUs and other packages in that?
Same situation. So as Raf was saying, it's incredible what's being wasted that way. But the regulations in the US are not such that we have to incinerate everything. So we only have to incinerate things that are considered regulated medical waste, which is things that are blood-soaked, more or less, or have some potential infectious material on it, or that are sharp. So most of it that we actually dispose of end up in a landfill, municipal waste, which make up about 2/3. 1/3 is about regulated waste, which will be incinerated or autoclaved. But we recently found out that much of what's in there doesn't even need to go into regulated waste and could be put into landfills or into sanitary drains. So more details about this, but we have maybe more potential to recycle directly because there's no need or no requirement to incinerate or autoclave much of that.
Thanks. And maybe staying with you, Professor Pohl, you were one of the authors of the ESGE statement, which is obviously a European statement. Do you have any knowledge or insight on the differences between the countries or regions in Europe that are actually putting this high or low on the agenda? What's your assessment of that?
So as you know, even though I'm from Germany, I practice in the United States. So I can only look from the outside. I can only say that from the perspective here, it's incredible what has been done in the UK. I mean, they are spearheading this whole movement for the past almost 15 years. I think they had it on their agenda in the UK, the national health system. And then the enthusiasm within the European Society of Gastrointestinal Endoscopy is really wonderful. A very enthusiastic group of fairly young physicians in the ESGE working group. And I know there are some dedicated work or some groups in Spain and Portugal that are very active. I mean, Ulrike Bayernhof can speak more about what's happening in Germany. I know in Germany there are a couple of centers that are really active, and in the Netherlands too, in Belgium. So, in France, I shouldn't even forget that. I mean, there's a lot of activity going on. So, in the US, yes, we have a strategic plan, which is more like the milestones to achieve without specific initiatives that are really, or like guidance, but the plan that we should follow. But it's kind of rolling out slow. So it's really a little bit inertia to get things going. There's some, there's a lot of enthusiastic people here too, but we need to get more organized and more structured. So I'm glad that there's this global effort and there's so much already going on in Europe and not just in Europe, but other countries too.
Okay, Professor Bishop, maybe to Belgium then. Let's make it concrete. How important is this for Belgium, and are the governments really on top of this issue?
I don't have that impression yet, but as Heiko was saying, I think UK was spearheading this, and then under the guidance of Enrique, who was really enthusiastic by the efforts in the UK, we have started this. And now you can see this usually what happens, then it spreads to the member society. So the Belgian Society is going to focus their meeting this year also on green endoscopy. So the interest is definitely rising. And you can see, as you said, Sebastian, is that the younger generation is onto that. In fact, we had a young fellow in the unit says, "Oh, Professor Bisschops, can I do a project on this? I would just want to see what we can save on waste if we recycle." And then it's like little steps that add on to each other. So we went to the hygiene department in the hospital and say, "Okay, you can do this. Start recycling," and we see what the outcome is. So, and these are the steps that. It's not so severe civil disobedience, but it's how it starts and how the interest is growing. So people become aware of it. And also in Belgium, this is now on the agenda. Not with the politicians yet. So I think that's usually the next step, I think.
Okay, and we've talked now about politicians and European associations. What's your view on industry in this whole part?
Oh, they are very much into this and very interested. So, and I think, I mean, it's again a knife that cuts at both ends. So because there's some benefit, especially if things can be refurbished and can be reused, and there are less severe restrictions on how packages should be developed and can be reused. But also they care about it. So I think there's a sincere involvement with the environment and a sincere concern about this, and they also want to take their responsibility. At least that's the impression I have when we have discussions with the industry at the European level.
Yeah,
certainly.
And we're talking at an industry event now here,
so
that's clear. One of the questions from the audience, maybe for you, Professor Sebastian, you're a positive person, as you already mentioned. So I think I will know what your answer will be, but the question is, do you foresee a future in endoscopy that could be entirely waste-free?
Yeah, I think that is taking optimism to the extreme. There will be some waste because we have lived centuries. We always produce waste as human race, so there will be waste. The key is how will we minimize it? And also whether that waste be useful for something else. Biomass, fuels, other things. There are a number of, we have a company in the UK which is now pretty much using every bit of non-contaminated medical waste into other recyclable items. So innovation will come as a result of this particular problem, which is a big problem, waste. I mean, Heiko has highlighted the degree of waste what we created each endoscopy. It is a problem, but we will come up with a solution in partnership with the industry. We'll want to reduce the waste. That will come through innovations, but we'll also have solutions to minimize and also perhaps use solutions to use the waste for other purposes. So I would say not going to be zero. It's not going to be a net zero waste, but we'll be minimizing.
Thanks for that. I'm also aware of the time. Professor Pohl, anything that you would like to add to that? Will it be waste-free in the future?
So the analogy with the garden. So if you consider weed something that you don't want, that's a weed. If you consider something useful, it's not weed anymore. So waste, similar situation. The question is, what do we do with this? So can we reuse it in some ways? Can we planet in a healthy way that is not polluting the planet, not harming the planet? So that's the key. And I think that would also be the goal. And I want to stay optimistic. That's part of the solution. I think we have to make that more and more happen.
Thanks for that. And then ending with you, Professor Bisschops, your last thoughts, wise words about waste.
Well, I couldn't agree more with what the two previous speakers said. So I think that's realistic. And looking at from a different angle, I think really collaborate with all the partners that are involved and rethink what we do in daily practice.
Thank you very much. I would very much like to thank the speakers from the different parts of the world. Thank the audience. We're going to have a 5-minute break and we will be back with you then.